Phacoemulsification in patients with a prior keratoplasty. Challenges in post-keratoplasty eyes, including the corneal stability and the endothelial cell count, together with irregular astigmatism and poor visualization regarding to the corneal hazy and scarring. Preoperative evaluation, including the graft assessment and the time since keratoplasty, should be more than 1 year, and doing specular microscopy to check the endothelial cell count, doing multiple formulas for the IOL calculation, and counseling the patient properly for higher risk of complication or graft rejection. Surgical modification and technique incision planning should be at the clear cornea away from the junction between the graft and the host, and temporal approach is recommended. Doing the phacoemulsification with lower ultrasound energy and higher vacuum, using dispersible OVD all the time of the surgery. Make your capsular 5 to 5.5 millimeter to secure the IOL in the capsular bag away from the cornea, and don't put the IOL in the antechamber. Keep the IOL inside the capsular bag. Corneal endothelial cell count wasn't detectable in my case because of corneal scarring and hazy cornea. I started with 2 paracentesis and 2.4 clear corneal incision away from the graft host junction, then backfill technique using the dispersive OVD to protect the back of the corneal graft, then starting the capsular rhexis. As we can see, it's about 5.5 millimeter, well centered, well sized. Then before doing the hydrodissection and hydrodelineation, empty the anterior chamber from the viscoelastic slightly. Then, as we can see, using the viscoelastic again to viscodissection of the cortex and the epinucleus, then spin and rotate the nucleus. As we can see, here is the emulsification. I started with shaping the cortex and epinucleus, then horizontal chop technique to split this dense nucleus in 2 halves, then emulsify each half into small fragments, then emulsify each fragments away from the back of the cornea with multiple use of dispersive OVD during the emulsification to protect the cornea and to minimize the risk of corneal decompensation in the postoperatively. As I said before, it's very important to decrease the ultrasound energy and use high vacuum while emulsification the dense nucleus. Then by manual irrigation, aspiration, removing the cortex, and also here try to avoid hitting the back of the cornea with the irrigation flow while holding the irrigation probe. As we can see also, I prefer to use low aspiration flow rate while removing the cortex. Then forming the capsular bag and the antechamber with cohesive OVD and implanting a single piece hydrophobic IOL inside the capsular bag away from the back of the cornea. It's secured properly inside the capsule. I prefer to avoid the AC IOL and also the sulcus IOL in those cases. Then stromal hydration through the host of the cornea. Here is the patient on the next day. Look at the clarity of the cornea and the clear graft, and the eye was very quiet with normal eye pressure. Thank you for watching.